Welcome to The Alcove. I'm Mark Malero. My guest today is Helen Epstein. She is a scientist and public health consultant who has written frequently on the HIV and AIDS crisis in Africa. She's here to discuss her powerful book, The Invisible Cure: Why We Are Losing the Fight Against AIDS in Africa, recently released in paperback. Welcome.
Thank you very much.
Now, it's interesting because you're a molecular biologist by training, and it's interesting because right now you're a public health consultant, and I'm wondering what originally drew you from the field of often insect study as a molecular biologist to go to Uganda to specifically look for a vaccine for HIV?
Well, I guess I was working as a postdoctoral researcher in California, and I realized at some point that I had a lot of friends who had died of AIDS, and I was very aware of this kind of catastrophe unfolding in this country particularly, and also around the world. And I guess I realized that in the end I cared more about those people than I did about my bugs that I was working on, although I cared about them too. But I really wanted to apply the things I'd learned as a scientist to this, to problems that were in the world at the time.
Now, was there something specific about Uganda that attracted you? I know they used to have the highest HIV infection rate. Was it that attracted you to Uganda, or?
Well, I think that's what attracted the researchers who hired me, for sure.
Okay.
It's also a remarkable place because it has a very sophisticated research community there of African scientists and researchers, and so there was a lot of work going on there then. There were a lot of people who would come in there to study and to try to help, and so it had the same feeling, oddly enough, even though it was halfway around the world, as New York did, in a weird way, in the 1980s, when AIDS was exploding in the gay community, and there was all this activity and all these incredibly dedicated people trying to fight it. It was the same thing in Uganda, but it was Ugandans doing it, and with some outside help.
Well, it's interesting because you say that epidemics like AIDS are embedded in the social ecology of the populations where they spread. Mm-hmm. And I'm wondering, was that something that you knew before you went to Africa, or was that something specific that your Ugandan experience taught you, that often, Western approaches to things like that are not necessarily the best way to approach it, that you should start with a local solution first?
I think that came to me much, much later, actually. I mean, at the time, what was interesting about what the book is really about is trying to understand why HIV is spreading so rapidly in Africa and why it's been so difficult to fight it, not only with a vaccine, but with other means as well, including behavioral change. But I think at that time, nobody was really talking about why the epidemic was so severe. I mean, if you actually look at what programs like the UN attributed the epidemic to, it was a vast list of different factors, many of which turn out, really probably not to have that much influence on AIDS. But mosquito bites, things. I mean, there are just, it was a great puzzle, and it was also something that, because of the fact that most people who were affected by AIDS were already suffered great stigma in the world already. Either they were, if they were African, or they were Haitian, or they were injecting drug users, or they were gay. It was something people really didn't want to talk about because it would seem to marginalize them further. But in a sense, delayed a pragmatic approach to fighting the disease and a rational approach to fighting the disease, because if you don't know why people are getting infected, how can you possibly help them unless you come up with a vaccine which really works, and we have really failed to do that.
And it's interesting too, because you note that it's very easy to be pessimistic about a place like Africa. A lot of people to this day are. But you note also that culturally there's something very interesting about Africa. There's a historic sense of solidarity to approaching problems. I was wondering if you could tell me about how you learned that, and were you surprised by that when you found that?
Yeah, sort of, yes and no. I mean, there's a kind of feeling you get when you arrive there, especially from the atomized, individualistic West, of great sense of sort of rather intense sense of community and cohesion among different people to which one is often rapidly absorbed. But I guess it didn't occur to me until much, much later how Ugandans in particular had managed to fight AIDS, because there's a delay between when HIV rates actually begin to fall and when scientists can measure it. It takes a few years for complicated reasons. And so when I was in Uganda in the early 1990s, HIV rates were plummeting all around us, even though none of us knew it, because our vaccines weren't working, various other approaches that people were trying to use weren't working. And we knew that, but we didn't know that something else was going on. And that only became apparent many years later. And why that happened only became apparent many years later. And I guess it was through conversations with researchers who had been studying it for a long time, maybe, I don't know, 5, 6 years ago, that I began to realize, oh my gosh, that's what was going on.
And what specifically was it? Was it local doctors and activists that were doing different solutions?
Yeah, and the government,
Okay.
which was working closely with its own researchers. And what it really was is that the Ugandans had an intuitive understanding of why HIV was spreading so rapidly in their communities. I mean, the message that has generally been, or the reason that's for which the AIDS epidemic has traditionally been attributed to the activities of so-called high-risk populations, people who have a lot of casual sex, prostitutes, truck drivers on truck routes, minors, and so on.
Right.
And this is not to say that these things don't matter, but the vast majority of people who contracted HIV in East and Southern Africa did not
Engage in high risk
did not
behavior.
engage in any of those behaviors. Yeah.
Right, because you note I think I don't know if it's specific to Africa, but you note the idea of concurrent relationships.
Right.
That there's an idea that there's a number of long-term partnerships that a lot of Africans have, and that can put you at high risk. I was
Right.
wondering if you could maybe explain that concept.
Yeah, the reason that HIV seems to be spreading so rapidly in East and Southern Africa, countries like South Africa, Lesotho, Botswana, Kenya, Tanzania, Malawi, and so on, is that it's not that people have so many sexual partners. In fact, they have fewer over a lifetime, or certainly not more than people in Western countries do,
Right.
even heterosexual people in Western countries. But they do have a greater tendency to have more than one long-term partnership at a time, perhaps 2 or 3. And this contrasts with the behavior more common in the West, which is serial monogamy, where we kind of generally, obviously there are exceptions everywhere, and there's a great deal of sort of sexual experimentation of all kinds among adolescents and young people in every culture, of course, but generally the pattern here is to kind of pledge undying love for one person for at
Right.
least a few months, if
It's
not
sort of
years.
part of our mythology
Yeah.
almost.
Exactly,
Right.
yeah, it's our culture. It's the
Sure.
basis of romantic culture since, for the past several hundred years. And this creates a kind of system where people are having one partner after another, but in much of East and Southern Africa, there is a greater tendency, it's hardly universal, but there's a greater tendency for men and women also to have overlapping long-term sexual relationships. So people will be sleeping regularly with maybe 2 people, maybe 3. And what this does, if enough people are doing this, it gives rise to a kind of interlocking network that serves as a kind of superhighway for HIV transmission, even though most people are having sex only with the people that they trust,
Right,
people
and
they trust and know.
and
Therefore, they
unprotected.
don't use condoms consistently in those relationships. Right. And so, and what's particularly tragic about it is that we all associate diseases with something dirty. We've done that since biblical times, basically. And so people naturally think, well, you get AIDS from a prostitute, you get AIDS from a truck driver, but in fact, you're getting AIDS from the people you care about and trust the most. That's what's really tragic.
Right. I'm also curious, you note the role of colonialism in Africa, that there's a lot of, if you go back to the British Empire and things like this, that there were a lot of workers that were migrant workers, and that created a lot of labor camps. Is that something that is as prevalent today as it was, let's say, 100 years ago? And does that still affect the way that diseases are transmitted?
I think it still exists for sure, and there's a great deal of migrant labor of both men and women moving all over the continent, actually, looking for work under often harsh circumstances. And this does promote a certain amount of sexual networking, but these patterns long predate that. I mean, I would say that the migrant labor system and the big mines that were built around in South Africa, for example, that attracted thousands and thousands, if not millions, of workers over the years, over the century, kind of exacerbated or made the situation worse because it, in a sense, that whole system was sustainable. What the mining companies would do is recruit men from their villages and, in a sense, force them by imposing taxes to go seek work in the mine so they could pay the taxes. But partly because of, perhaps because of traditions of polygamy, where men would traditionally have more than one family, it's possible that it's the other way around, that in a sense these pre-existing patterns of family life enabled, made the migrant labor system, which was extremely brutal and rigorous and difficult for many, many people, more palatable than it might have otherwise been.
Okay. And you also note there's very much a gender struggle, like there is in every continent in Africa, but specifically with AIDS, there's a lot of women that are struggling for modernity. And I'm wondering if you could maybe just explain to us how their struggle for modernity, for women's rights affects HIV rates, affects their ability to protect themselves.
Well, I think I got interested in this because one of the things that's very striking and has struck a lot of people is that there's a very powerful relationship between domestic violence, particularly, and also other forms of sexual violence and HIV. I mean, there are very, very high rates of domestic violence in these countries, and they're much publicized, and they're very, very serious. And there needs to be a much broader conversation about this in these countries. But the relationship with HIV was sort of striking. Most researchers that I had read had attributed it to the fact that women could not, women were at risk of it. Women who have been beaten or raped by, especially by a, what's interesting is that women who have been beaten or raped by an acquaintance or a stranger are actually not more at risk of HIV in South Africa than other women who have not been raped or by a stranger or an acquaintance, which is sort of odd. People, I mean, there are people who have been raped by strangers and acquaintances who become HIV positive, but their risk is not greater. Your risk is far greater if you have been attacked in an intimate partnership by someone that you're close to,
which
like
is
a
common.
Spouse or boyfriend.
Right.
That is extremely common, much more common than stranger rape or acquaintance rape. Intimate partner rape is very, very common, and coercive sex within these relationships, and that's really risky from the point of HIV. And the reason most researchers have said that the reason for this is that the women are intimidated, they can't negotiate condom use. But in fact, that may be true in many cases, but often people aren't using condoms in these relationships anyway, number one. And number two, what seems to be happening, if you actually examine what people are fighting about there, which is probably not that dissimilar from what people fight about here, it's about infidelity. It's about the fact that a man will come home, the woman says, "Where have you been?" He says, "You have no right to ask me that," and beats her up, maybe coerces her to have sex. Or he says, "You're accusing me, I'm accusing you," or whatever. And so it's a huge power struggle between men and women that results in this violence very, very often. And so in other words, the tendency for men and women to have multiple sexual partners exacerbates not just their risk of HIV, but also the risk of violence in the relationship, because norms are shifting. This is a part of the world that is an enormous social flux at the moment. It's what I call the African earthquake, and it's essentially an earthquake in gender relations. And the women are somehow pulling ahead of the men in many respects. and they're aspiring towards a more kind of modern norm of a companionate marriage where the ideal is monogamy.
Right.
And men often who have suffered a great deal of humiliation at the hands of colonialism and apartheid and knew sort of the vast unemployment in this region, often see their ideal relationship differently. They believe, many of them still believe, not all, that they have a right to multiple partnerships.
I was wondering, you noted the idea of transactional sexual relationships. I'm wondering if you can maybe just first explain that concept, and is that as prevalent as these gender roles are shifting? Is that as prevalent as when you first saw it, when you discovered it?
Well, these gender roles have been shifting for 30 years long, or 40, 50 years long before I ever got there, so it's a slow earthquake. But it's, but in terms of, I mean, one thing that's confused people a great deal, if we get back to what is the underlying cause of the HIV epidemic in Africa, is that there's a great deal of what researchers refer to as transactional sex. And this kind of polite term really refers, in my mind, to something other than prostitution, although prostitution is also transactional. In both cases, an exchange of money, goods, or something is made between two people who have sex. But with prostitution, the exchange is essentially a cold-hearted, there's no relationship there. It's a cold-hearted exchange of, some set price for one given act of sex. Whereas in transactional sex, as I think of it, it's more, the relationship is totally different. It's if a boy gives a girl some gift or something, it's a symbol of commitment, and that he's coming back and he's going to bring more.
But of course, it's also a form of power.
It's also a form of power, absolutely.
Right.
And with the rates of poverty, the soaring rates of inequality, also, money has a great deal of power in that region now, even tiny amounts of money.
I'm wondering if you speak of the various countries in sort of sub-Saharan Africa, if you look at Uganda's success, I'm wondering if you compare that with a country like South Africa. You were quite critical of President Mbeki's often, I guess, denial of these antiretroviral drugs and delaying a lot of change there. I'm wondering if you can sort of compare and contrast the Ugandan success story versus something like South Africa, where it took a lot longer to reach an ability to kind of lower the rates of infection.
Well, South Africa still hasn't lowered the rates of infection.
It still hasn't?
No,
okay.
Nothing. So, but I guess I would, if we're going to, I do, not, President Thabo Mbeki has a great deal to answer for in South Africa, but the failure to prevent the spread of HIV, I actually have stronger words to say about the West, about failing to learn the lessons of Uganda, than I do about South Africa.
Okay, and what would those be?
There have been a great many HIV prevention programs funded by Western countries in Africa over the past, really since I first started going there, since the early 1990s. And they have tended to stress either the promotion of condom use or the promotion, more recently, the promotion of abstinence that's really gotten underway in the past 5 years or so. But before that, it was essentially, we will just pave the streets with condoms and everything will be fine. And data, which was rather dubiously collected, was actually used to support this, on both sides, to support both approaches.
Yeah.
And sort of gathered, unfortunately, by certain Western researchers to justify programs that we now know will have a very limited impact, both the abstinence and the condoms. And unfortunately, there were a great many interests involved in promoting those particular approaches, and we now know not only that they will have a limited approach, but we know why.
And the thing is, well, first of all, why will they have a limited effect? Because you talk about the culture wars often being responsible for different aspects of approach, whether it's condom use and, again, a focus on partner reduction, or on things that might be more evangelical in nature, where it's more about abstinence. I'm wondering, why were they ineffective? Was it because they weren't working in tandem? Were they often fighting politically for the same kinds of funds?
No.
Yeah.
They weren't working because essentially, because of this network effect, which we now understand much better than we did, but we could have understood 10 years ago because the data was all there. It was all available to everything. Everything I've told you about the network, we could have known 10 years ago. But the fact is, because of that network, we've already discussed why condoms will have a limited effect. Essentially, people are becoming infected mainly in long-term relationships in which it's very difficult to maintain long-term condom use.
Right.
Anyone who's married and is trying not to have a kid knows that that's not a winning idea. We also know that the kind of strict abstinence education that is promoted through churches and other religious-based education groups also has a limited effect. It may delay people's sexual activity, but eventually everyone becomes sexually active. And what happens in Africa is when you become sexually active, even if you become sexually active at 24, if your partner is part of this kind of super highway that's out there, you reach out and I mean, he can infect you right away, or she. And so it doesn't matter how long you wait. If you ever start having sex, which everybody does at some point, you are at great risk unless something is done about I mean, universal monogamy is an impossible goal anywhere, including in Africa. But what people can do, and what people did in Uganda, was reduce their partners. And it's been shown, you can even show this mathematically, or you can show it with diagrams, that even if you break up the network a little bit, everyone doesn't have to suddenly go monogamous, but if you break up the network and reduce especially those casual partnerships that do take place, which often feed the virus onto the network, if you reduce those partnerships and keep people sort of within their sort of corral, so to speak, at least with the limited numbers of partners that they have, and try to keep everything within a circuit, small circuit, then you can have a very powerful effect on the HIV rate. For example, among the many activities that the Ugandans had, they had a very powerful campaign which was known as zero grazing, which meant stick within your paddock and stick to the partners that you have. It didn't mean, abstain and be faithful, but it meant sort of, don't be stupid. And there was also even, there were large numbers of women's groups that were church groups, government agents, and so on, who were all reinforcing this message. And there was even something called the Ugandan Association of Co-Wives and Concubines that kind of would police the behavior of polygamous men to ensure that they didn't graze outside of the family and endanger everyone else.
Now I'm wondering, do Western aid agencies, whether it's U.S. AIDS and UN AIDS, do they get this now?
Now they do.
You had a long time, a hard time convincing them, for instance, with partner reduction, that scientifically this was valid. Is there a tendency in the scientific community, especially in the West, to have a form of sort of groupthink that if people get research money to do a certain kind of study, they're quite invested in that study, and they, obviously they want to approach things in a certain way? Is it difficult to get different agencies talking to each other? Because it seems to me that some form of compromise ultimately would be what works. And if you look at the Ugandan situation, it was them on a local level doing many things, taking Western money, but applying it in a local way, doing it in a multi-pronged approach that ultimately proved successful.
Yeah. I think what really matters, we can get back to the culture wars now that I've had my rant, but I think for a long time there was an enormous amount of groupthink, which was actually very defensive, and there was a feeling on the side of the more sort of left-leaning agencies, such as the United Nations AIDS program, for example, that they don't even mention partner reduction anywhere in any document, virtually, almost. Maybe there's a tiny mention. There'll be paragraphs and paragraphs and paragraphs about condoms. There'll even be some mention of abstinence. Partner reduction is all but absent.
Do you know why?
In any of their documents
Yeah.
and reports, and concurrency is nowhere mentioned. And that is quite striking. And when I've tried to ask officials at the UNAIDS program about this, I met with silence. They answer a different question than the one I asked. And I think it's partly a paranoia that I am somehow some agent of the abstinence-only preaching Christian right or something like that, which I'm not, because I think that they are also full of baloney.
Yeah, you seem to have equal criticism for both sides.
Yes, I'm getting attacked on all sides at the moment.
Well, I was going to say,
I've also been praised by both sides, but I've also been attacked by both sides. And essentially, so the abstinence people have, so in a sense, there were these two groups. They had fundamentally different views about, what is ultimately, sex is always a moral issue for somebody. So
and a political issue.
Yeah, and so science really went out the window in both sides. I mean, you can even find documents where people on the right attributed Uganda's success to abstinence. It was not a success for abstinence. The teenage pregnancy rate rose when HIV rate was falling. And you can find people on the left who will attribute Uganda's success to condoms, which really didn't come into the country and start being used regularly until after the HIV rate had declined. So in other words, there's a vast literature on each side which is completely missing the target.
Now, are you seeing a change with that literature? Because you note that AIDS is such an emotional issue. Are you seeing a change in the way that these various agencies look at funding, in the way that they're saying, wait a minute, we need to maybe have a more multi-pronged approach, and we need to be talking with other people, because different groups that may have completely different agendas, obviously if they're talking, ultimately it would seem to sort of a reasonable person that would lead to some kind of positive change, whether it's social or scientific.
Yeah.
Are you seeing a change in the way that people are approaching it?
Yeah, definitely, yeah.
You are.
No, there are a large number of groups who have now moving into, much more rational campaigns. I mean, it's sort of always a mixed bag, and people are doing all kinds of things, but there's a much greater effort now underway, and in the next few years you'll hear more about it, but there are a number of campaigns underway now that are being developed, and some of them I'm working on, some of them I'm just aware of, that are trying to inform people about the dangers of these networks that they pose even to faithful people, people with only one partner. Because if you're on the spokes of this network, obviously you're also at risk. If you're faithful to a person who isn't faithful to you or who wasn't faithful to you in the past, you're at huge risk. So that message, finally, is just being incorporated into prevention programs, never too late, and also the crucial message of reduce your partners or use condoms as consistently as you possibly can. Those messages, finally, which are really finally based on a rational approach to this epidemic, are a number of groups, especially, including some from America.
Yeah, it's getting through, finally.
It is.
I'm wondering, on a personal level for you, how do you balance just strict science, looking at data, interpreting it, analyzing it, collecting it, versus policy? For instance, you're such a public health advocate, and you obviously have your own beliefs. How do you balance an approach to science and then, for instance, aspects of reportage or journalism when you're writing a book like this and you've written for a number of publications? How do you find a level of objectivity and yet a level of commitment to what you believe in and the kind of change that you want to see?
I guess that's what science is for, actually.
Sure.
It's a kind of a sort of religion with me, I suppose, because I'm not actually otherwise religious, but I do believe that as much as possible, we have to try to tell the truth. And if you're going to say that you're trying to help poor people fight this terrible plague, you have to really do the best you can. And I guess when I don't see that happening, it creates, this is good journalism.
Sure.
So, I suppose
that inspires the journalistic aspect, yeah. I'm also wondering, how do you look at the continent of Africa when you first arrived in 1993 in Uganda? And when you think of Africa now, is it a completely different way that you look at Africa? Because you obviously love the diverse cultures there. You have an appreciation for the people. How do you view Africa, and also how has that continent changed you in terms of your life, the way that you approach your life, science, advocacy?
Gosh. I guess what I was sort of surprised about, and I think many people are surprised by, is, I mean, I didn't really know what to expect. I mean, I knew what most Americans know about Africa when I first went there. I'd had all sorts of fantasies about it. When I was a kid, I used to canoe across the living room on the footstool and stuff like that, thinking I was in the Zambezi. But otherwise, I didn't, you know, I guess I didn't realize how, I guess the picture that I'd had was the usual sort of bloodbath pictures and chaos and so on. And what I didn't understand was that the vast majority of the continent is at peace. It's actually developing quite rapidly. There are an enormous number of very competent people there working extremely hard. And what's sort of remarkable about it is, you know, in a sense, increasingly, things are getting a bit difficult in America at the moment, but for a long time I'd always felt, well, people here, you know, kind of live to consume things and to improve the lives of their children, make them as strong as possible and so on, but they're not really living for something larger than themselves. And you do feel in Africa that people are really trying to build a new world in some ways, and it's amazing to see it happening and to be, you know, to feel like every once in a while that you might be on a tiny part of it is very exciting, actually.
Maybe my last question for you is, you note towards the end of the book that there is no actual magic bullet, obviously, for AIDS. What should we be focusing on? There has been some success in reducing HIV rates in certain countries. What should we be thinking about? I know that recently in the papers they were talking about that HIV funding is still controversial, getting people to commit, getting governments, the UN, to commit to pledged amounts of money that they're putting in. If you're talking to policy people out there, talking to bureaucrats out there, what kind of message do you want to give them in terms of where they should focus, how we should look at, let's say, the next 10 years of research?
Well, I guess that's a tricky question. I know at the moment, yeah, there's a lot of head scratching and reassessing and saying, well, you know, where has all this money gone? And I think part of, you know, there has been, again, this kind of great swings in just as there has been between condoms and abstinence and so on. There's a great tendency during the 1990s to completely ignore the epidemic, and then in the early 2000s to sort of start fire hosing money all over the continent.
Right, which was problematic.
Which was extremely problematic because a lot of it sort of went missing. We have no idea what it was spent on, and it, you know, in some cases may have promoted a kind of cynicism among people there, so that, you know, often the people who actually were really committed to the cause and helping to treat people, care for orphans and so on, were totally overlooked in all of this. And a lot of other sort of carpetbagger types got the money, both African and American and European and so on, and maybe it wasn't such a good thing. And so what I'm hoping is that these discussions, and also the new understanding, which is also, I should mention, male circumcision also has now turned out to be highly protective, although not perfectly protective against HIV infection. And we need to, in addition to promoting this idea of partner reduction and education about the networks, and also programs to promote better gender relations through discussions, and especially in communities between men and women. And that's a whole other issue. We need to do something about improving services for safe, voluntary male circumcision. However, in general, we need to use all of this to develop a rational approach to the epidemic so that we are neither ignoring it nor throwing money all over the place.
Does there also need to be a focus on local solutions? How much of it should be sort of an imported rational solution that's sort of grafted onto a local culture? Is there a way that
Well, I think
that
much
varies?
more dialogue. There tends to be very little dialogue between the people who are designing these programs and the people who are supposed to be receiving them. And so there's more, depends on the program. Some of them are much more collaborative than others, but they need to be much more so. And to give an example of that, I think at the moment there's a lot of debate around the new bill for to reauthorize the President's Emergency Plan for AIDS Relief, or PEPFAR, which is a proposed $50 billion program over 10 years, I guess, to support work on AIDS treatment, care, prevention, and so on, and research, I think, in Africa in particular, but other developing countries too. And there's a small group of Republican congressmen who would like to ensure that at least 50% of that money in each country goes to HIV treatment programs. But in some of these countries, I mean, they're a little, there are countries where there are a few hundred people with HIV.
So
but there's a potential.
Overkill.
It's way overkill, and it does seem like one wonders, what is the motivation for earmarking money for drugs and medical supplies and so on? Is that some congressmen have certain links to those kinds of companies? Whose interests are they really serving here? And there was, in fact, a delegation of African health officials who came to Washington and said, let us decide in collaboration with the U.S. government exactly how this money would most efficiently be spent.
Right.
We should decide this together, and we should decide it based on the nature of the epidemic in our countries, not based on what you think we should be spending it on, just based on some arbitrary decision that we don't understand. And I must say I support them.
And I was going to say, on the other side, is there a way of having, let's say, UNAIDS or some other agency vet local officials to make sure that on the local side that there isn't corruption that takes over, because that sometimes happens.
I don't know whether UNAIDS is the best choice to do that vetting.
Is there an agency that exists yet, or would you recommend the creation of sort of an oversight?
Well, existing ministries of health, for example, have long received donor funding for all sorts of purposes, and increasingly there is, I think one of the things that's happened over the past few years, and that may have led to some of the chaos, is that there was a real feeling that, oh, we can't trust African governments, they're too corrupt and so on. But there have been new mechanisms to track monies that's spent through governments and so on, and if we're ever going to get these countries to develop, they have to have governments that can do things and deliver services to their people in a transparent manner. And I would, there are existing mechanisms to do that in these countries, and the countries are increasingly willing to cooperate with those mechanisms. But if you start doing things like imposing kind of all sorts of little parallel programs, doing this little oddball thing over here, and having some preachers over here,
right,
having some people, it becomes a sort of dog's breakfast, and nobody knows what's going on. And so I would. I think it actually isn't that hard to communicate with people and work together always.
Okay, very good. Well, thank you very much for being here.
Thanks so much.
Thank you. And thanks for being with us. We'll see you again soon.